In this chapter, you will get a clear picture of the anatomy and physiology of the heart. That way you can know what it means when we say the heart depolarizes and understand what the heart's electrical system looks like. From this section, you should learn the details you need to know about how the heart is oxygenated, gets its blood supply, and innervated, gets its nerve supply. You probably don't need any convincing to believe that the heart is a vital organ in your body. It is so important that ancient scholars felt it was the seat of the soul. Its main job, of course, is to pump the 4 to 5 liters of blood you have inside your vessels from place to place inside the body. Every cell of the body, except red blood cells, desperately needs the oxygen blood delivers. Without it, some cells, such as brain cells, would die within a few minutes. If your heart contracts at 75 beats per minute, or BPM, the average is 60 to 100 BPM, this means your heart beats about 108,000 times each day and more than 39 million times per year. If a person lives for 75 years, their heart will beat over 3 billion times. Each time your heart contracts, about 70 milliliters of blood are ejected from it and begin circulation. Your blood vessels add up to a total length of 100,000 miles that must be traversed with each beat. This makes the average cardiac output 5.25 liters of blood per minute. Over the course of a year, this adds up to 2.6 million gallons of recycled blood, or about 10 million liters. To be that resilient and predictable every minute of your life, your heart needs to be an amazingly built organ. Your heart is located in your thoracic cavity between the two lungs, commonly known as the chest, in what's called the mediastinal space or mediastinum. A tough structure resembling an orange peel called the pericardium physically separates the heart from the rest of the thoracic structures. It largely fills up the space between your spine in the back and the sternum or breastplate in the front. This is what it looks like in place. The heart has an upper and lower border. Surprisingly, the base of the heart is at the top of the structure and the apex is at the bottom. The base is where the great vessels enter and leave the heart, while the apex is where the bottoms of the ventricles are located. If you think of the heart as a tube of toothpaste, it squeezes first from this part of the heart in an upward direction to eject blood out the top of the heart base. The heart is slightly rotated in the chest, with the right side more anterior than the left. Remember that the terms right and left refer to how the person sees their own body, not to how you perceive it standing in front of them. The apex is slightly on the left side of the chest and fits nicely into the cardiac notch of the left lung's inferior lobe. This is basically a depressed area, necessary to make room for the heart. How big is the heart? It depends on the size of the person. Larger people naturally have a bigger heart. The average size is about 5 inches, 12 centimeters from top to bottom, 2.5 inches, 6 centimeters from back to front, and 3 inches, 8 centimeters from side to side. It weighs about 9 to 10 ounces, 250 to 300 grams in women, and about 10 to 12 ounces, 300 to 350 good in men. Since athletes work their heart muscles hard, are their hearts bigger than average for their size and gender? However, you probably know that larger is not always better when it comes to the heart. Enlarged hearts in most people are a bad thing and often indicate some type of heart failure. We will go into great detail about the different parts of the heart, but the general sections in a nutshell include: there are 4 chambers in the human heart, 2 atria, right and left, which largely receive blood, and 2 ventricles, again right and left, which are the heart's ejecting chambers. The ventricles are larger and have thicker walls than the atria. The heart pumps blood through 2 separate circuits. The pulmonary circuit on the right side takes blood without much oxygen, called deoxygenated, and sends it to the lungs. Position of the heart in the thoracic cavity: right lung, mediastinum; sternum, right atrium, right ventricle; left lung, second rib, left atrium, left ventricle; thoracic vertebra, posterior, diaphragm; apex of heart, cross-sectional view; aortic, arch, cut; heart, in mediastinum, anterior. Each sentence can be long if the input requires it, but must not exceed 30 words. If a sentence is longer, split it into 2 or more natural sentences without altering the content. This is where oxygen comes in from your breathing and reoxygenates the blood, sending it back to the heart. The systemic circuit on the left then takes this blood, now called oxygenated, and sends it to the body's cells where the oxygen is extracted. Main arteries and veins. Blood enters and leaves the heart through the great vessels, including the superior and inferior vena cava, pulmonary trunk, arteries and veins, and the aorta. All blood exiting the heart leaves through an artery, and all blood enters the heart through a vein. The oxygenation status of the vessel does not determine whether a vessel is an artery or a vein. Membranes and layers. The heart is kept in place and prevented from overexpanding by the pericardial layer. This structure itself has 2 layers known as the fibrous and serous layers. The fibrous layer is tough and made from inelastic connective tissue, while the serous layer is thin and makes a small amount of fluid surrounding the heart to reduce friction as the heart contracts. The serous layer has an outer parietal layer and an inner visceral layer. This inner visceral layer is really the epicardium, which is the outer layer attached firmly to the heart muscle. The heart wall also has a thick myocardium and an inner endocardium. A cross-section of the heart and pericardium would look like this. Pericardial cavity. Fibrous pericardium. Endocardium. Myocardium. Parietal layer of serous pericardium. Epicardium. Visceral layer of serous pericardium. Surface features. The surface of the heart is not smooth. You can see an extension near the top of the heart on either side called auricles, or sometimes atrial appendages because they stick out from the atria. Valleys are also seen on the heart called sulci leach, singularly known as a sulcus, grooves where the coronary vessels can pass along the heart surface. You'll see that the major one of these is the anterior interventricular sulcus running down the front of the heart, while a similar posterior interventricular sulcus is on the backside. There is also a coronary sulcus that divides the atria and ventricles as shown. Heart location and surface structures. Anterior. Posterior. Inferior. Coronary sulcus divides atria and ventricles. Interventricular sulci divide the left and right ventricles. Myocardium. The myocardium or muscle layer of the heart does not have the same thickness all around, but rather is thickest in the left ventricle and thinnest in the atria. It is also not a flat sheet of muscle cells, but is swirled around the ventricles in order to help them pump blood more efficiently. This is what this swirl pattern looks like. Left ventricle, right ventricle, contracted, relaxed, inside the heart. The heart's chambers are separated by walls called septa, the singular form being septum. There are several of these, including the interatrial septum, or between the two atria. As babies, we each had a hole in this septum called the foramen ovale, which was used in utero to get blood to bypass the shrunken lungs in the womb. This hole should close shortly after birth, but it can take up to 6 months. Once it does, it leaves behind a depression called the fossa ovalis. A flap near this hole is called the septum primum, and it is this flap that provides the tissue to make the fossa ovalis after birth. This is what the foramen ovale looks like. Aorta. Pulmonary artery. Left atrium. Patent foramen. Ovale. There are 4 major valves in the heart. The other 2 septa in the heart are the atrioventricular and interventricular septa. Valves. Cardiac muscle of the left ventricle. These septa are reinforced in many ways by the cardiac skeleton made from dense connective tissue which helps form the heart's overall structure. Skeleton of the heart including fibrous rings around valves. Pulmonary semilunar valve. In order of when blood passes through them, they include the tricuspid valve, atrioventricular, the pulmonic valve, semilunar, the mitral valve, another atrioventricular, and the aortic valve, another semilunar. Aortic semilunar valve. Cardiac muscle of the right ventricle. Before we get any further, let's look at the path blood takes through the heart, starting at the periphery, the end point of the systemic circulation, and ending with the blood re-entering systemic circulation. The interventricular septum is important because it houses the major electrical pathways of the heart. Skeleton of the heart. This is what it looks like in the heart. Tricuspid valve. Right atrium. Bicuspid valve. Pathways of blood. There are no valves entering the heart from the periphery of the body or from the lungs themselves. It is a multi-ringed structure through which several other structures pass. Blood enters in a deoxygenated state, represented here by blue arrows. It isn't really blue in real life, but more a deep burgundy, even though your veins look blue from the outside. It enters the right atrium through the superior and inferior vena cavae, and then travels through the tricuspid valve and into the right ventricle. Blood is then ejected from this ventricle through the pulmonary or pulmonic valve, entering the lungs through the pulmonary artery. After getting oxygenated in the lungs, the blood enters the left atrium. From there it travels through the mitral valve into the left ventricle. This oxygenated blood, represented by the red arrows, leaves the heart until the next time around, through the aortic valve and into the aorta itself. Now that you know the basics, we'll delve further into the heart's structures and physiology. Let's start by looking at each heart chamber in more detail so you know what they look like and what they're for. Then we'll look at other aspects of the heart, including the all-important electrical system, which is essentially what the ECG measures, heart chambers. Now that you know what the major chambers are in the human heart, and how blood flows through them, let's look at each one in turn. They aren't just empty chambers, each has a unique function in the heart itself. We'll look at them in the order of how blood flows through each one. The right atrium. The right atrium is the receptacle for deoxygenated blood. Blood from the upper body enters the right atrium through the superior vena cava, while blood from the lower half of the body enters from the inferior vena cava. This chamber marks the right-sided border of the heart. Its appendage, or right auricle, is on the front and medial side, its job being to allow for improvement in the right atrium's capacity. The lower surface of this atrium is a two-part structure with a ridged separation between the two called the crista terminalis. This ridge has no purpose other than to mark the two separate aspects of the right atrium called the sinus venarum and the atrium proper. The sinus venarum is in the back part of the inferior atrium and is the part that first receives the blood from the vena cavae. It comes from an embryonic structure called the sinus venus. The atrium proper is where the auricular appendage is located. It comes from the primitive atrium of the embryo. Its walls are rougher and more muscular than the sinus venarum. Finally, there is a tiny coronary sinus in the atrial wall, basically a hole, that receives the deoxygenated blood from the coronary veins. This is the basic structure of the right atrium. Between the atria is the interatrial septum, a muscular wall region separating the two atria. As mentioned, this is where the fossa ovalis is located. Once the site of the foramen ovale, it closes immediately at the moment of birth. Did you know one of the most common heart defects seen at birth is an atrial septal defect? It most commonly happens in the area of the foramen ovale. Most of the time it doesn't lead to symptoms because the left atrial pressure is greater than the right. It means that blood gets recycled without any deoxygenated blood passing from right to left. However, if the defect is large, it can put extra strain on the right heart, which can cause increased pressure in the lungs and eventually right-sided heart. The right ventricle. The right ventricle receives blood from the right atrium through the tricuspid valve. Its job is to pump the blood into the lungs to be oxygenated. The ventricle is shaped like an upside-down triangle and is what you see when looking at the heart's surface front part. There are two ill-defined parts to this chamber, one for inflow and the other for outflow. These have a ridge dividing them called the supraventricular crest. The inflow aspect of this chamber is rough and muscular. The trabeculae carnae form an irregular web or sponge-like surface on the inside of the chamber wall. These include two features known as ridges and bridges. The ridges are just muscular structures, while the bridges contain some of the most important electrical conduction pathways of the heart. There are also pillars which are actually muscles that attach to the tricuspid valves. Their job is to prevent the valve from flopping back or prolapsing into the right atrium as it closes. There are three papillary muscles to match the three leaflets of the valve. These are the structures you'll see. The upper outflow part of the right ventricle is called the conus arteriosus. It is smooth-walled and made from an embryonic structure different from the inflow part of the right ventricle. The interventricular septum is the wall between the two ventricles. It has a membranous portion and a muscular portion. The membranous portion is the smaller of the two, while the muscular layer is thicker by far. This membranous layer is actually part of the fibrous skeleton we've already talked about. The left atrium. The left atrium is another receiving chamber in the heart. It receives oxygenated blood from four pulmonary veins coming in from the left and right lungs. It is the structure you'll see if you look at the back or posterior border of the heart as a whole. It also has an auricular appendage coming from its upper border near the pulmonary trunk. Like other heart chambers, it has two distinct parts of diverse embryological origins. The smooth-walled inflow part is what takes blood from the pulmonary veins, while the outflow part is more anterior. The auricular appendage is located there, and it is lined with its own muscles called the pectinate muscles. The outflow to this chamber is the mitral valve, which leads into the left ventricle. The left ventricle. The left ventricle gets its blood from the left atrium before using its muscular strength to pump blood out to the periphery via the aorta. It is the major structure you'll see when looking at the apex of the heart and along its left border. There are inflow and outflow portions to this chamber, as is true of the right ventricle as well. The inflow receives the blood first. It has papillary muscles that are attached to cords called the chordae tendineae, which are themselves attached to the two mitral valve leaflets. Ridges represent the trabeculae corneae, just as in the right ventricle. The outflow tract has a smooth lining and is also called the aortic vestibule. In this last part of the heart, the blood flows through before leaving, exiting through the aortic valve to the aorta itself. Heart valves. The various valves of the heart help to ensure that blood flow happens in a forward direction at all times. Your heart would be very inefficient if these valves were not there or if they didn't work well. The blood would go backwards just as much as forwards. The four valves of the heart are divided into two subtypes, the atrioventricular and the semilunar. The atrioventricular or AV valves include the tricuspid and mitral valves. These are strong connective tissue-based valves between the atria and ventricles. They are both notable for having papillary muscles attached to them to prevent potential backflow of blood. The semilunar valves are remembered best if you note that the word semilunar means half moon. Both of these valves have 3 leaflets shaped like a half moon. The 2 valves of this type include the pulmonic valve and the aortic valve, both outflow valves from the heart itself. This is what these valves look like in the cardiac skeleton. If you remember that the cardiac skeleton is like a disc with holes in it, you can see that these valves are actually quite close to one another. Posterior, bicuspid valve. Cuspia valli. Right side of the heart. Left side of the heart. Aortic valve. Pulmonary valve. Anterior. It can be hard to remember which valves are opening and which are closing at any given moment. Essentially, you can think of these processes in 2 halves. The AV valves both open or close simultaneously, and the same is true of the semilunar valves. This is why most of the time you'll hear a lub-dub sound when listening to the heart and not 4 separate sounds. The lub comes from both AV valves closing, which makes a sound you can hear. The dub comes from the 2 semilunar valves closing. In some cases you will hear what's called a split S1 lub or split S2 dub, which means you hear the 2 valves close at slightly different times. Sometimes this is normal and sometimes not. The 2 AV valves close when systole or contraction of the ventricles starts. As this is the time blood is ejected from the heart, you certainly don't want it to go backward here. The 2 valves are known. Tricuspid, the valve between the right atrium and right ventricle. There are 3 cusps or leaflets called the anterior, posterior and septal. Each has at least one of the chordae tendineae attached to it. These connective tissue bands are the tendons to the tiny papillary muscles attached to them. Enricular wall so that the valve doesn't prolapse backward during a forceful contraction. Mitral, the valve between the left atrium and the left ventricle. Unlike the tricuspid valve, it has 2 leaflets or cusps. The name comes from the shape, which looked like a bishop's mitre to whoever named it. It also has chordae tendineae, but has 2 papillary muscles instead of the 3 seen in the tricuspid valve. These are the valves and the papillary muscles involved with them. The semilunar valves, the pulmonic and aortic, prevent backflow after blood has exited the heart. The pulmonic valve has 3 cusps that open out into the pulmonary trunk, while the aortic valve opens out into the aorta. These valves can be leaky or regurgitant and narrowed or stenotic for various reasons. Did you know? One of the main causes of a narrowed mitral valve or mitral stenosis is having rheumatic fever in childhood. Rheumatic fever is a disease that starts with a strep throat infection. Some people will have a strong immune reaction to the bacteria, leading to an inflamed valve. Over the course of several years, the valve gets scarred. This valve will narrow over time, causing mitral valve stenosis years later. It's a good reason to take antibiotics for strep throat. Both of these semilunar valves are similar, having 3 leaflets or cusps each. Each forms a tiny cup facing the outflow part of the valve called the sinuses. In the aorta, for example, 2 of the 3 sinuses have openings for the coronary arteries. Both the left and right coronary arteries come off the aorta directly through sinus openings, as shown. You can imagine why these cusps are helpful. As blood pushes back on them after leaving the heart, the cusps catch the blood and are forced to close as a result. Heart wall structure. The heart wall has 3 known layers, each of which has a specific function. From the inside to the outside, you'll find the endocardium, myocardium, and epicardium. Let's look more closely at each. The endocardium is the layer on the inside of the heart wall, lining the wall itself as well as the valves. It is made from connective tissue with an overlying layer of epithelium, very similar to the layer that lines each of the blood vessels. You might not think it is essential, but it helps during development and afterwards helps regulate the way the heart contracts. This is the endocardium and other cardiac wall layers. Endocarditis means inflammation of the endocardium. Many things can cause it, but a common one is a bacterial infection. Bacteria will settle on the valves because blood flow is turbulent in those locations. This can be dangerous because they can form tiny clusters of blood clots and bacteria called vegetations. These vegetations and clots can break off, causing them to travel to other areas of the body. In the worst cases, the person can have a stroke if the clots travel to the brain or other areas and cause permanent death to an organ or tissue. There is a thin layer beneath the endocardium itself called the subendocardial layer. It is essentially an attachment point for the endocardium to connect to the heart's myocardium or muscle layer. You'll see later that some of the main conducting nerve fibers in the heart travel in this sublayer. This means that damage to this particular layer can affect the electrical activity in the heart. The myocardium is very thick with involuntary muscle fibers specific to the heart called cardiac muscle fibers. Interestingly, they are linked together through connections called intercalated discs, even though they are small individually. These are necessary for the cells to communicate with one another rapidly, so the cells can act in a synchronized way. With the heart muscle especially, you wouldn't want these cells to go rogue and do their own thing. This would lead to chaos and an inability for the heart to work as a unified unit. This is why the heart muscle is referred to as a syncytium, even though it really isn't one. A true syncytium is a group of cells that have actually fused. The myocardium isn't made from fused cells, but they communicate easily with one another because of the intercalated discs, and so are a functional syncytium. This is what they look like. Just outside this muscle layer is the subepicardial layer. It is essentially the connective tissue that attaches the myocardium to the epicardium of the heart. The epicardium is the outer layer of the heart wall. It is the same thing as the visceral pericardial layer, and is what makes the pericardial lubricating fluid. When you think about the pericardium and its layers, you should recognize that they don't surround the heart. Instead, imagine that the pericardium is a big deflated parachute that drapes over all the surfaces of the heart. So there is the illusion of it surrounding the entire organ, even though embryologically it just began by draping over the heart muscle during development. It explains why there is a thin layer inside and a tougher layer outside. The coronary circulation. The coronary circulation is so named because it forms a crown of sorts that surrounds the entire heart. We've talked about how this circulation starts at the sinuses just outside the aortic valve, one opening leading to the heart's right side and the other to the left. Here is an anterior front-on view of the heart and these major coronary arteries. You might think it isn't important to know each of these arteries and which part of the heart they supply, but in fact it is significant and relevant. When you read an ECG and look at the different leads, you will sometimes see specific patterns indicating that one or another artery has been affected or blocked. You must know which arteries are where to determine what a particular pattern of ischemia or oxygen deficit means. As you can see, there are left and right coronary arteries. The left gives rise to three major branches: the anterior descending artery, the circumflex artery, and the marginal artery. About 1 out of 4 of us have an extra branch off the left circumflex artery called the posterior interventricular artery. The right coronary artery gives rise to a marginal artery across the right anterior part of the heart, or the posterior interventricular artery in 1 out of 4 of us who have this artery coming off the left circumflex artery. So if you see certain areas of ischemia or heart damage, you should think of these branches possibly being blocked. Anterior surface, think left anterior descending artery. Left anterior surface, think left marginal artery. Left posterior surface, think circumflex artery. Right anterior surface, think right marginal artery. Right posterior surface, think posterior interventricular artery. Inferior surface, think right marginal artery. This is a rough idea of what this looks like visually. Left circumflex artery supplies the left atrium and left ventricle. The left anterior descending artery supplies the right ventricle, left ventricle, and interventricular septum. The left marginal artery supplies the left ventricle. The right coronary artery supplies the right atrium and the right ventricle. Right marginal artery supplies the right ventricle and the apex. Once the blood has supplied the heart structures, it enters the cardiac venous system. Tiny Thebesian veins run through the myocardium, taking blood to larger veins outside the heart muscle. These lead into even larger veins that travel along the sulci alongside the arteries until they reach the coronary sinus, a large area where blood pools and travels along the coronary sulcus. The coronary sinus empties into the right atrium through a small opening. Here are the major veins of the heart, including the coronary sinus. It is not as important to learn the different names of the coronary veins, as these rarely get diseased and aren't a cause of any major ECG changes. Blood flow through the heart wall. The blood flow through the heart wall itself has one important feature. The major coronary vessels travel along the outside of the heart, but what about the circulation inside the heart itself? It turns out there are perforating arterioles, or extra small arteries, that punch through the heart wall from outside to inside so that even the endocardium gets blood. It also means that if there is a slowing or blockage of blood flow in the major coronary arteries, the inner heart wall layers, especially the endocardium and subendocardial areas, are more likely to be shorter on oxygen than the outside of the heart wall. As you study ECG analysis further, you'll learn how the ECG will show areas of ischemia where there isn't enough oxygen in the heart muscle. You'll hear about transmural myocardial infarctions and subendocardial infarctions. The term transmural means all through the heart, while the term subendocardial means the damage is confined to the inner heart layers. You will probably not hear about an epicardial myocardial infarction because this isn't likely to happen, since the blood supply is generally much better in this part of the heart. Because the blood flows from outside to inside, you wouldn't have damage to the outer layers of the heart wall without likely having worsened conditions in the inner heart layers at the same time and in the same areas. What does the pericardium do? The pericardium is an important structure around the heart. It keeps the heart fixed in space, mostly because this covering around the heart is attached to the diaphragm. It's also attached to the great vessels and the sternum overlying the heart. It keeps the heart constrained when it comes to potentially overfilling. The fibrous pericardium is very tough and limits heart movement. Because of the serous layer around the heart, there is effective lubrication as the heart beats, avoiding friction. In some ways, the pericardium also protects the heart from outside infections. Blood supply to the heart. There are a couple of things to think about when learning about the blood supply to the heart. There are the blood vessels that enter and leave the heart in obvious ways. Certainly you can say that the entirety of your blood supply enters and leaves your heart frequently. In fact, with a normal cardiac output, you shuttle your entire blood supply completely around the loop every single minute. But this isn't the same thing as when we talk about the blood supply to the heart itself, which comes only from the coronary arteries that surround the organ. As we talk about blood supply, we'll do it in order from just before entering the heart to just after leaving it. As you know now, the process starts when the vessels enter the right atrium through two large veins known as the inferior and superior vena cava. The inferior vena cava takes blood from below the diaphragm back to the heart to be pumped into the lungs. Far below this vein are the two common iliac veins in the pelvis, one for draining blood from each leg. There is very little pressure in the venous system, so the veins have valves that help prevent blood from pooling in your feet every time you stand up. Movement of the leg muscles and thin muscles around the veins help squeeze blood upward toward the heart. The superior vena cava takes blood from the upper body except the heart itself and sends it to the right atrium. The brachiocephalic veins come together in the thoracic region to drain both sides of the upper body. It comes down along the right side of the chest before entering the heart. You can see in this image that several jugular veins drain the facial and brain areas. The next main vessel when it comes to blood flowing through the heart is the pulmonary trunk. It comes off the heart as a single vessel, drawing blood out of the right ventricle to each lung. The pulmonary trunk itself is short, quickly separating into the left and right pulmonary arteries. These arteries have many branches that get progressively smaller in diameter until they become capillaries. It's these tiny capillaries that interface in the lungs to collect oxygen and give off carbon dioxide. This process of gas diffusion in the lungs is largely a matter of physics. The concentration of oxygen gas in the lungs, air sacs or alveoli, is higher than the concentration of this gas in the deoxygenated capillaries. This naturally means that oxygen will flow from high concentration areas to areas of low concentration. The reverse is true for carbon dioxide. Because of cell metabolism, which gives off CO2 as a result, the concentration of CO2 in the veins is higher than in the alveoli. This gas therefore diffuses from the inside of the capillaries into the alveoli proper. This is what gas exchange looks like in these alveoli. The four major pulmonary veins, two on each side, gather all the blood from the lungs, now oxygenated, drawing it into the left atrium. They do not come together but instead have separate entry points into the left atrium as shown. This leaves us with the aorta, which is ready to receive oxygenated blood from the left ventricle so it can go out to the periphery, the systemic circulation, again. Blood is essentially ejected upward for a few inches until it reaches the aortic arch, a true arch that makes a 180-degree turn in order to send blood down to the lower extremities. This arch has its own branches that send blood to the head and neck as well as both upper arms. These major branches look like this. The coronary circulation. The coronary circulation is so named because it forms a crown of sorts that surrounds the entire heart. We've talked about how this circulation starts at the sinuses just outside the aortic valve, one opening leading to the heart's right side and the other to the left. Here is an anterior, front-on view of the heart and these major coronary arteries. You might think it isn't important to know each of these arteries and which part of the heart they supply, but in fact it is significant and relevant. When you read an ECG and look at the different leads, you will sometimes see specific patterns indicating that one or another artery has been affected or blocked. You must know which arteries are where to determine what a particular pattern of ischemia or oxygen deficit means. As you can see, there are left and right coronary arteries. The left gives rise to three major branches: the anterior descending artery, the circumflex artery, and the marginal artery. About 1 out of 4 of us have an extra branch off the left circumflex artery called the posterior interventricular artery. The right coronary artery gives rise to a marginal artery across the right anterior part of the heart, or the posterior interventricular artery in 1 out of 4 of us who have this artery coming off the left circumflex artery. So if you see certain areas of ischemia or heart damage, you should think of these branches possibly being blocked. Anterior surface, think left anterior descending artery. Left anterior surface, think left marginal artery. Left posterior surface, think circumflex artery. Right anterior surface, think right marginal artery. Right posterior surface, think posterior interventricular artery. Inferior surface, think right marginal artery. This is a rough idea of what this looks like visually. Left circumflex artery supplies the left atrium and left ventricle. The left anterior descending artery supplies the right ventricle, left ventricle, and interventricular septum. The left marginal artery supplies the left ventricle. The right coronary artery supplies the right atrium and the right ventricle. Right marginal artery supplies the right ventricle and the apex. Once the blood has supplied the heart structures, it enters the cardiac venous system. Tiny Thebesian veins run through the myocardium, taking blood to larger veins outside the heart muscle. These lead into even larger veins that travel along the sulci alongside the arteries until they reach the coronary sinus, a large area where blood pools and travels along the coronary sulcus. The coronary sinus empties into the right atrium through a small opening. Here are the major veins of the heart, including the coronary sinus. It is not as important to learn the different names of the coronary veins, as these rarely get diseased and aren't a cause of any major ECG changes. Blood flow through the heart wall. The blood flow through the heart wall itself has one important feature. The major coronary vessels travel along the outside of the heart, but what about the circulation inside the heart itself? It turns out there are perforating arterioles, or extra small arteries, that punch through the heart wall from outside to inside so that even the endocardium gets blood. It also means that if there is a slowing or blockage of blood flow in the major coronary arteries, the inner heart wall layers, especially the endocardium and subendocardial areas, are more likely to be shorter on oxygen than the outside of the heart wall. As you study ECG analysis further, you'll learn how the ECG will show areas of ischemia where there isn't enough oxygen in the heart muscle. You'll hear about transmural myocardial infarctions and subendocardial infarctions. The term transmural means all through the heart, while the term subendocardial means the damage is confined to the inner heart layers. You will probably not hear about an epicardial myocardial infarction because this isn't likely to happen, since the blood supply is generally much better in this part of the heart. Because the blood flows from outside to inside, you wouldn't have damage to the outer layers of the heart wall without likely having worsened conditions in the inner heart layers at the same time and in the same areas. The physiology of the heart muscle cell or myocyte. Heart muscle cells or myocytes have a unique feature not shared by other cells in the body. They have the ability to respond to an electrical signal and generate an action potential. This causes each muscle to contract as a result. What's unique about them is that they are somewhat leaky, so they don't keep a normal electrical charge steady at all times. They do not necessarily have to wait until they get a signal from elsewhere in order to contract. And because some electrolytes leak through the cell membrane, they can cause their own action potential without outside influence. This is called autorhythmicity. Before we get into that, let's look at what a resting potential looks like and how it is created. The resting potential of a cell is the electrical charge difference between its inside and outside. Most of this charge difference comes because of the different amounts of charged ions due to the cell's sodium-potassium ATPase pump that is continually pumping sodium out of the cell and potassium in. Because it sends out 3 sodium ions for every 2 potassium ions pumped in, the cell is steadily charged more negatively on the inside, called the resting potential. It looks like this: sodium, potassium, pump 3 Na plus out, 2 Kepos in. ATP. ADP. P. Active translocation needs ATP to pump. 3 sodium ions are pumped out of the cell. 2 potassium ions are pumped into the cell. An action potential for any cell involves a change in the charge differential or voltage across the membrane. Usually it happens when sodium enters the cell, causing a more positive charge inside, called phase 0. Let's look at how this works. Cardiac muscle action potential. Plateau, maintained depolarization due to K inflow when voltage-gated slow K channels open and K outflow when some K channels open. Repolarization due to closure of S channels and K-deg outflow when additional voltage-gated K channels open. Membrane potential, MV. Rapid depolarization due to Na inflow when voltage-gated fast Na channels open. 60, 80, 100, L, 0.3 sec. The normal heart muscle cell has a resting potential of about 90 mVas across the membrane, being more negative on the inside. This is called phase 4 for some weird reason. Sodium enters the cell in phase 1. This starts the process known as depolarization. The sodium ions add a positive charge so that the cell is temporarily positively charged. The charge returning to its resting state is called repolarization. This whole process of depolarization and repolarization is called the action potential. There are several different potassium channels in the cell membrane. In phase 4, a series of leaky potassium and calcium channels allows the membrane potential to change slightly. This takes it to a 70 MeV state. This inherent leakiness is what triggers the heart muscle cell to spontaneously fire and contract without outside influence. Then in phase 0, sodium channels open and sodium floods in. The charge in the cell becomes positive at about plus 50 pounds MeVs, after which the sodium channels close quickly. Phase 1 then starts. as potassium channels open up to allow potassium to actively leave the cell, driving down the electrical gradient. Phase 2 is when the charge differential plateaus, staying the same because calcium levels become high in the cell to keep the charge positive for a period of time. After phase 2 ends, the calcium channels close and calcium is pumped into the cell's sarcoplasmic reticulum. At the same time, potassium leaves the cell in phase 3. This rapidly depolarizes the cell, essentially taking it from its plus 50 MeV state back to its former 90. Of course, it is during this entire time that the cardiac muscle cell contracts. Cardiomyocyte contraction. The whole goal of this action potential is to cause muscle contraction. How does this happen? It's similar in some ways to how all muscle cells contract. There are fibers called actin and myosin that slide along each other to shorten the cardiac muscle cell. If you look at it, it appears a lot like this. In the image you see just one sarcomere, which is a unit of actin and myosin fibers in the cell. There are thousands of sarcomeres lined end to end and up to 100,000 sarcomeres per muscle fiber in a skeletal muscle fiber, although there is far less a cardiac muscle fiber because they are smaller cells. As you can see, the actin fibers are attached to the Z discs, while the myosin fibers are free, sort of. As the muscle contracts, bridges form between the actin and myosin fibers where they overlap. The contraction progressively shortens the muscle because the fibers walk along each other to shorten the sarcomere. This whole process takes both calcium ions and ATP energy. Calcium is stored in the sarcoplasmic reticulum of the heart muscle, a fancy name for the cell's endoplasmic reticulum. When the voltage increases inside the cell during depolarization, there are channels in the sarcoplasmic reticulum that respond to the voltage change by releasing the calcium ions, called voltage-gated calcium channels, because the gate that causes their release is the voltage. This image is what it looks like. The sarcoplasmic reticulum surrounds each sarcomere so it can quickly release calcium where it is needed. T-tubules extend like pathways for the electrical impulse to come from the cell's outer surface to the deep interior regions where the sarcomeres can be quickly acted on. Calcium release is essential to muscle contractions of all kinds. You'll see in this image why. There are two proteins on the actin fiber called troponin and tropomyosin. These don't bind to myosin because the tropomyosin is blocking the myosin binding site. Calcium binds to troponin and moves the tropomyosin out of the way. This exposes a binding site on the actin fiber where myosin can attach. Myosin has an extension coming off of it at certain intervals. This extension binds to the actin, forming a bridge between the two strands. The strands would normally just stay that way, except for the fact that ATP energy enters the picture. It causes what's called a power stroke, where the bridge strokes in one direction to slide the fibers along with each other by just a tiny distance. The cross bridge then breaks with the help of ATP again. It causes the extension to reattach farther down the line. The whole thing repeats itself regularly until the sarcomere, where the whole muscle fiber shortens noticeably. To stop the contraction, calcium is pumped back into the sarcoplasmic reticulum. This will cover the actin binding sites again so that the muscle relaxes. The cardiac pacemaker cell. There are two different types of muscle cells which you can think of as leaders and followers. Leader cells are small pacemaker cells that set the rhythm of the heart, called, depending on the part, the sinoatrial node, or SA, atrioventricular node, or AV, and a string of cells extending down the interventricular septum and into the ventricles called the bundle of His, atrioventricular bundle, and Purkinje fibers. They are located here. Each of these pacemaker cells has automaticity and the ability to generate its own action potential, but they do it at different rates. The SA node has the fastest rate of automaticity, so it sets the other cells pace too. If it fails, however, the other cells also have automaticity, but at a slower rate. The SA node is the main cardiac pacemaker of the heart. Why? Mainly because it has the fastest rate of automaticity. It sets the pace for the rest of the heart at an average heart rate of 60-100 BPM. When it sends this beat signal to the other parts of the heart's conducting system, it overrides any depolarizations those other parts might themselves have, essentially conducting the orchestra and giving no chance for other pacemaker cells to have their own autorhythmicity. Bad. Some heart rhythm problems that typically result in a rapid heart rate come from what's called a re-entry rhythm. It involves continual recycling of stimulation to the AV node through a circular pathway in one of these SA to AV node pathways. The heart's electrical normal pathway is from the SA node to the AV node to the bundle of His to the left and right bundle branches and finally to the Purkinje fibers. If the SA node fails, therefore, the heart does not stop beating altogether. The next area in line, the AV node in this case, will kick in and set its own rhythm. Because they aren't as leaky as the SA node, the AV node cells will cause a slower rate. The average heart rate generated in each of the main conducting areas of the heart is this. The cardiac cycle can be thought of in two different ways, as the pathway of blood through the heart or the pressure changes that happen in the heart. In this section, we will talk about the pressure changes that occur throughout the cardiac cycle. The two main phases of the cardiac cycle are systole and diastole. In systole, the ventricles contract. Even though the right ventricle has a thinner muscular wall and less strength, it sends the same amount of blood out of it as the left ventricle. It really has to be this way, otherwise blood will pool somewhere in the body, in the lungs, or perhaps the systemic circulation. An equal amount of blood needs to flow properly through the entire heart. Diastole is the time of ventricular filling. The mitral and tricuspid valves both open to allow the atria to contract and push blood into the ventricles. It comes in two phases, and in the second there is an atrial kick that pushes as much blood into the ventricles as possible, about 20% of the total blood entering the ventricles. This happens immediately before ventricular systole. In this image, which shows left ventricular pressure, the last rise in diastole comes from the atrial kick, labeled diastole in the first section and systole in the middle section. As the ventricle contracts, it isn't the same type the entire time. Pressure changes in the ventricles happen in four phases, called the isovolumic relaxation phase, ventricular filling phase, isovolumic contraction phase, and rapid ventricular ejection phase. Isovolumic relaxation is when the aortic valve and mitral valve are both closed. The ventricle relaxes but doesn't fill. The mitral valve is induced to open because of this low pressure situation, so blood can flow into the ventricle in the ventricular filling phase. As the ventricle contracts first, both the mitral and aortic valves are closed. As the ventricular ejection phase starts, the aortic valve, and this valve only, opens so that blood can leave the heart itself. The maximum and minimum pressures in the heart chambers are left ventricle, 15 to 120 ml. Right ventricle, 5 to 25 ml. Right atria, 4 to 5 ml. Pulmonary arteries and left atria, 10 to 25 ml. Aorta, 80 to 20 ml. Preload, afterload, and contractility. The terms preload and afterload are confusing in heart physiology, but are nevertheless important to understand. They are pressure numbers that happen at certain stages of the cardiac cycle. This is a basic look at preload and afterload. Preload and afterload. Preload, afterload. Preload, volume of blood in ventricles at the end of diastole, end of diastolic pressure. Afterload resistance left ventricle must overcome to circulate blood. Preload is also called the LVDP, or left ventricular end diastolic pressure. It is a measure of how much the ventricular wall is stretched at the end of diastole. Preload influences several things, including the stroke volume, how much blood is ejected from each ventricle during systole, and the cardiac output, the amount of blood the heart pumps per minute. It also influences how the heart functions. As the preload or pressure increases, the heart muscle fibers stretch normally, and there is tension on the muscle wall. However, the muscle will contract normally in the heart, so that the heart's output will be normal in a non-diseased heart. The Frank-Starling curve was designed by two physiologists, Otto Frank and Ernest Henry Starling, who looked at what happens to the heart if preload is increased. They looked at the extremes of too low and too high preloads. Their work led to this curve, which looks at the pressures in the ventricle, cardiomyocyte contraction. The whole goal of this action potential is to cause muscle contraction. How does this happen? It's similar in some ways to how all muscle cells contract. There are fibers called actin and myosin that slide along each other to shorten the cardiac muscle cell. If you look at it, it appears a lot like this. In the image you see just one sarcomere, which is a unit of actin and myosin fibers in the cell. There are thousands of sarcomeres lined end to end, and up to 100,000 sarcomeres per muscle fiber in a skeletal muscle fiber, although there is far less a cardiac muscle fiber because they are smaller cells. As you can see, the actin fibers are attached to the Z discs, while the myosin fibers are free, sort of. As the muscle contracts, bridges form between the actin and myosin fibers where they overlap. The contraction progressively shortens the muscle because the fibers walk along each other to shorten the sarcomere. This whole process takes both calcium ions and ATP energy. Calcium is stored in the sarcoplasmic reticulum of the heart muscle, a fancy name for the cell's endoplasmic reticulum. When the voltage increases inside the cell during depolarization, there are channels in the sarcoplasmic reticulum that respond to the voltage change by releasing the calcium ions, called voltage-gated calcium channels, because the gate that causes their release is the voltage. This image is what it looks like. The sarcoplasmic reticulum surrounds each sarcomere so it can quickly release calcium where it is needed. T-tubules extend like pathways for the electrical impulse to come from the cell's outer surface to the deep interior regions where the sarcomeres can be quickly acted on. Calcium release is essential to muscle contractions of all kinds. You'll see in this image why. There are two proteins on the actin fiber called troponin and tropomyosin. These don't bind to myosin because the tropomyosin is blocking the myosin binding site. Calcium binds to troponin and moves the tropomyosin out of the way. This exposes a binding site on the actin fiber where myosin can attach. Myosin has an extension coming off of it at certain intervals. This extension binds to the actin, forming a bridge between the two strands. The strands would normally just stay that way, except for the fact that ATP energy enters the picture. It causes what's called a power stroke, where the bridge strokes in one direction to slide the fibers along with each other by just a tiny distance. The cross bridge then breaks with the help of ATP again. It causes the extension to reattach farther down the line. The whole thing repeats itself regularly until the sarcomere, where the whole muscle fiber shortens noticeably. To stop the contraction, calcium is pumped back into the sarcoplasmic reticulum. This will cover the actin binding sites again so that the muscle relaxes. The cardiac pacemaker cell. There are two different types of muscle cells which you can think of as leaders and followers. Leader cells are small pacemaker cells that set the rhythm of the heart, called, depending on the part, the sinoatrial node or SA, atrioventricular node or AV, and a string of cells extending down the interventricular septum and into the ventricles called the bundle of His, atrioventricular bundle, and Purkinje fibers. They are located here. Each of these pacemaker cells has automaticity and the ability to generate its own action potential, but they do it at different rates. The SA node has the fastest rate of automaticity, so it sets the other cells' pace too. If it fails, however, the other cells also have automaticity, but at a slower rate. The SA node is the main cardiac pacemaker of the heart. Why? Mainly because it has the fastest rate of automaticity. It sets the pace for the rest of the heart at an average heart rate of 60-100 BPM. When it sends this beat signal to the other parts of the heart's conducting system, it overrides any depolarizations those other parts might themselves have, essentially conducting the orchestra and giving no chance for other pacemaker cells to have their own autorhythmicity. Bad. Some heart rhythm problems that typically result in a rapid heart rate come from what's called a re-entry rhythm. It involves continual recycling of stimulation to the AV node through a circular pathway in one of these SA to AV node pathways. The heart's electrical normal pathway is from the SA node to the AV node to the bundle of His to the left and right bundle branches and finally to the Purkinje fibers. If the SA node fails, therefore, the heart does not stop beating altogether. The next area in line, the AV node in this case, will kick in and set its own rhythm. Because they aren't as leaky as the SA node, the AV node cells will cause a slower rate. The average heart rate generated in each of the main conducting areas of the heart is this. In heart failure, if left ventricular volume is too high, it can lead to a boggy heart that doesn't contract normally. The stroke volume is the total area under the curve. When the ventricular volume is high, the stroke volume isn't as robust as it should be. How do you measure the preload? You can introduce a catheter and measure the pulmonary capillary wedge pressure. This measures the pressure in a small pulmonary artery that is occluded by the catheter. This measures the back pressure in the left atrium because there is no valve or pressure gradient between the left atrium and the right atrium. This pressure measurement correlates with preload. The afterload is best described as the force that opposes the ejection of blood from the heart. This is calculated as the total force opposing the heart muscle's contraction minus the heart's existing force before the contraction, essentially the load or pressure the heart must push against. You can't really know what this value is for sure because it depends on the ventricular shape over time. So we use arterial pressure or blood pressure as a substitute measure. The afterload affects the end systolic volume in the ventricles, the left end diastolic pressure, and the stroke volume. This is just like the fuel injector of your car ejecting fuel to propel itself. If there is a blockage or if the tube leading out of the injector is too narrow, it will be harder for the injector to do its job. In the case of your heart, your cardiac output will fall mostly because there isn't enough blood pushing out of the heart with each beat. The Frank-Starling curve looks at the effect of changes in afterload on the heart's function. The higher the afterload, the greater the chance that the heart gives out, and the person goes into heart failure. This is a lot like the pump failure of any pump that is overworked. Notice the lines on the last curve that measure contractility. This is also called inotropy, which is the strength of each contraction. A poorly contracting heart does not shorten its fibers when the contraction is happening. Essentially, the heart is weaker than it should be. This is common in many types of heart failure. How we measure heart performance. One of the measures of heart function is called cardiac output, or how much blood the heart puts out per minute. This is an easy calculation if you have an echocardiogram, an ultrasound of the heart that measures how much blood is ejected from the heart per beat. It's only the amount ejected from you that gets the cardiac output. It looks like this. Cardiac output, CO il heart rate HR, x stroke volume, SV, CO il HR x end diastolic volume, end systolic volume. CO is about 4 to 5 liters per minute at rest. EF, ejection fraction, is the percentage of end diastolic volume ejected with each beat. EF is 50 to 70% in normal PEEP. If the heart has poor contractility, it will be like a baggy sack and have a poor ability to push blood out. You will often note a high end diastolic volume and a low ejection fraction, which is the percent of blood pumped out of a filled ventricle with each heartbeat. This is because such a large and boggy heart simply can't contract well enough to push blood out of the ventricles. But the good news is that cardiac output increases dramatically with exercise. Transmission of electrical impulses. Electrical activity is a natural property of biological cells, although electricity is not really the right term here. In reality, it is electrochemistry we talk about when dealing with the electricity of the body. This means that the electricity comes from ions that are themselves electrically charged. When ions move from one place to another, usually across a membrane or down a membrane, this is where the electricity comes from. Even though it is chemical electricity, it can still be measured. This is why the ECG can pick up the electrical signals from the heart, because you can pick up such signals from nerve cells and muscle cells too. An electromyogram picks up the electricity that comes from the muscle cells, and a nerve conduction study picks up the electrical flow through a nerve. An EEG or electroencephalogram measures the electrical patterns in the brain. There are charged molecules throughout the body, but the ones that participate in nerve and muscle cells' electrical activity are mainly ions, usually charged atoms or small molecules. The ones you might be most familiar with are electrolytes. When you measure a person's electrolytes, you usually measure the sodium, potassium, chloride, and bicarbonate levels. Calcium is an ion that is also essential in the heart, mostly because it is necessary for the heart muscle to contract. Let's look again at the action potential to see what we mean by absolute and refractory heart muscle contraction periods. An absolute refractory period is when the heart muscle cell can't be reactivated to make another action potential. This is a good thing because it means the heart can't just go wild and beat whenever it wants. You need this refractory period to prevent serious heart rhythm disturbances or arrhythmias. This image shows when the absolute refractory period is during the action potential. The absolute refractory period is a pause button on the heart muscle's ability to be restimulated to contract again, expressed as the amount of time it takes. During the absolute refractory period, the cell membrane's sodium and calcium channels are inactive, so it is impossible to start another action potential. The difference between the absolute and relative refractory periods is easy to remember. The absolute refractory period is when it is impossible to have any new action potential, while the relative refractory period is when there is a possibility that a new action potential could happen, but it would be harder to do. This period occurs right after an action potential moves down the axon, so it would have to occur by a larger than normal stimulus. The image doesn't show that when potassium exits the cell to cause repolarization, there is a period called hyperpolarization. It's when the potassium overshoots the goal and causes too much electronegativity in the cell. The cell could still depolarize during this time, but it would take a larger stimulus in order to do this. When the resting potential returns to normal, the relative refractory period ends. It isn't shown in the above image because it represents a regular muscle cell's action potential, but in pacemaker cells in the heart, such as the SA node, the action potential looks different. It has a certain threshold of 40 MeV that triggers the action potential to happen. Before this, there are the leaky sodium channels, also called funny sodium channels, that slowly leak sodium into the cell. When it reaches the magic threshold, both sodium and calcium rapidly enter the cell through different channels. The repolarization happens with a fast outflow of potassium out of the cell. These cells don't need a long break, as you see with the heart's cardiomyocytes' drawn-out action potential, because they don't contract, although they do hyperpolarize, as you can see, where the line drops below the threshold. These funny sodium channels start up and pace the cell's electrical output by leaking sodium back into the pacemaker cell. Funny channels are called that because they leak both sodium and potassium at different times. These channels flow in what's called the pacemaker current because they set the cell's pacemaker activity and are the whole reason the heart has inherent automaticity. What the ECG signals mean. Before we talk about what the ECG signals mean on a small scale, you should review what happens as the heart's electrical system functions in real time. As you know, in a healthy person, the SA node starts initiating a heartbeat because it has the fastest rate of automaticity. It sends that signal across the atria, signaling these muscles to contract. As you can imagine, this starts blood flowing through the ventricles as they fill during diastole. The electrical signal also reaches the AV node. This node is critical because there is a pause or delay in the passage onward of the electrical signal here. If you know how the heart works, you'll see why this is important. If the signal reached the ventricles too fast, they would contract before they had a chance to fill up with blood. The whole thing would be out of sync. The resting period or delay in the AV node helps allow for this filling up of the ventricles, lasting about 120 milliseconds. After the AV node, the signal goes down the bundle of His and splits into the left and right bundle branches. Then they travel in a wide array around the ventricles through the Purkinje fibers. As you can see, these will cause the ventricles to squeeze upward like a tube of toothpaste to send blood up to the semilunar valves and outside the heart itself. See how coordinated the whole thing is? It is truly a symphony of electrical activity and contractions that allow blood to effectively flow through the heart and eject from it. Did you know? Artificial pacemakers are used to keep the heart going at a regular pace when it can't do it by itself. A wire is passed into the heart through the veins leading to the organ, then inserted into the heart muscle. It paces the heart by sending regular signals for it to contract. It works best for slow heartbeats or bradycardia, and is harder to be effective for fast heartbeats or tachycardia because the pacemaker has difficulty interrupting a faster rate than its own. Remember that the fastest pacemaker to the heart wins and therefore sets the overall heart rate. Now we get to the interesting stuff about what happens to the heart's electrical activity during a single beat. It is the electrical activity you'll see every time you read an ECG, and we will talk a lot more about this in a minute. But first, here is what the typical electrical activity looks like in a single heartbeat. The paper used on an ECG is designed so that each tiny 1 millimeter per square in width equals 0.04 seconds, and each 1 millimeter in height stands for 0.01 millivolts in electrical activity. This means that the strip outputs at a pace of 25 millimeters per second, and that 10 millimeters 1 centimeter equals 1 millivolt. The beat starts with a P wave, representing the electrical activity you'll see when the atria depolarize or begin to contract. The space between the beginning of the P wave and the start of the next wave, the R wave, is called the PR interval. This represents atrial depolarization to the beginning of ventricular depolarization or contraction. Within there is an even smaller part called the PR segment, which is the space between the end of the P wave and the start of the R wave. The QRS complex is next. It starts with a slight downward deflection called the Q wave, then peaks upward to make a deflection called the R wave. Then it drops sharply down to the S wave before moving back up to the baseline. The width of the QRS complex is important in knowing if the AV node is working properly. It should be relatively narrow. It reflects the time of ventricular depolarization. Hidden inside the QRS complex is the repolarization wave. This means the atria are returning to a resting state wave of the atria. You can't actually see it because the QRS complex hides it. After the QRS complex is the ST segment between the S peak and the beginning of the T wave. The ST interval isn't as important clinically, but it is the interval between the S peak and the end of the T wave. The T wave represents the time of ventricular repolarization or the ventricles returning to a state of rest. Not everyone has a U wave. It is usually an abnormal finding in the heart. It is a tiny wave that is thought to occur when the Purkinje fibers depolarize, but really no one knows this for sure. The next image shows what is happening in the cardiac cycle during a single cycle. The artificial beginning of the cycle is during both atrial diastole and ventricular diastole. The P wave is the electrical beginning of the cardiac cycle. Note that the start of both the atria and ventricles systole happens essentially at the peak of the P wave and QRS complex respectively. This is because these parts of the heart muscle need the electrical impulse first before they can contract. To be sure, the heart is capable of beating by itself with nothing more than a good blood supply. If this weren't possible, you could never have a heart transplant, since with transplants of any kind, including the heart, you don't ever connect the nerves. Instead, without nerves, the denervated, the transplanted heart still beats at about 90 to 100 BPM by itself. Let's see how the normal heart operates. In the medulla oblongata or lower brainstem, there are nuclei, collections of nerve cell bodies, that regulate the heart rate. These contain the nerve cells for have two major branches, the sympathetic and the autonomic nervous system. This system is parasympathetic. The sympathetic nervous system is the fight or flight system of the heart, which causes it to beat more rapidly. Just as you would notice if you were suddenly frightened by something, the parasympathetic nervous system has the opposite effect, slowing the heart rate. There are nerves for both of these branches that attach to the heart to influence the heart rate. You may have heard of the vagus nerve. It is the 10th cranial nerve and the main supplier of parasympathetic nervous system activity to the heart. When it influences the heart to slow it down, this is called the vagal brake, acting on the heart. The process isn't entirely automatic because you can purposely think of a scary thing and cause your heart to race. Your thoughts come from the cortex and travel through the hypothalamus to the medulla oblongata. This will activate the sympathetic or parasympathetic branches to affect your heart rate and blood pressure, But it can happen without thinking as well, because you can sense danger from your body without full conscious thought. Such a thing will also influence the brainstem and affect your heart rate and blood pressure. The brainstem's two main nuclei are the nucleus tractus solitarius, NTS, or solitary nucleus, which is influenced by chemical receptors, as well as ones called baroreceptors that monitor your blood pressure. When this gets activated, it turns off the rostral ventrolateral medulla's nucleus to put out sympathetic nervous activity. The parasympathetic neurons in the dorsal vagal nucleus and the nucleus ambiguus, also in the medulla, get activated by the NTS. They trigger the activity of the 10th cranial nerve, slowing the heart rate significantly. The heart always has some vagal break from this nerve all the time, so that the actual normal heart rate is less than the denervated set point of about 100 beats per minute. The hypothalamus also has a role in all this. If you are stressed from exercise or excessive heat, it is for occur if you are sick or anxious. For example, this will stress the sympathetic nervous system in order to speed the heart rate. It will also, there are a couple of terms you should know concerning the heart and its innervation, including chronotropy. This is related to the heart rate itself and essentially means anything that can change it. A positive chronotropic agent will speed up the heart, while a negative chronotropic, the agent will slow it down. Inotropy. This refers to the strength or force of the contraction. Some drugs will increase the heart's inotropy and others will decrease it. Dromotropy. This refers to the velocity of electricity through the cardiac conduction system. Sympathetic influence on the heart will increase the heart's dromotropy, while parasympathetic influence will decrease it. Various medications can positively and negatively affect the heart's dromotrophy. There is regular innervation of the heart that has nothing to do with the autonomic nervous system. This comes from the phrenic nerve, which emerges from the neck at the cervical roots 3, 4 and 5 through the 5th cervical vertebral area. This provides sensory and motor innervation to the pericardium and diaphragm. It can often cause chest pain that isn't coming from the heart itself, but instead is a referred pain that only feels like it. To sum things up, you now know a lot more about the heart than perhaps you've ever learned before. It is a vital organ necessary for our survival. Its main job is to pump blood to the lungs for oxygenation, and then pump the oxygenated blood to the rest of the body. It has 2 atrial chambers that receive blood and 2 ventricular chambers that eject blood. The heart's electrical system or conduction system is how the heart can regulate the contractions in a specific way. There is the main pacemaker of the heart called the sinoatrial node or SA node. The signal it creates gets sent to all parts of the heart in a specific pattern. As each heart muscle fiber or cardiomyocyte gets activated, the heart will contract in a unified fashion to allow it to act as a functional syncytium, which squeezes blood out like you'd squeeze a tube of toothpaste.